All right, welcome everybody to our February Comagine Health Patient Family Partnership Hub. We are so glad to have you all here today. We'll go ahead and get started. As you all know, we've got all the Zoom features. We've got, if you want to private message someone, you're more than welcome to. Just click on their name in the chat. We do have live transcript available. It's actually called captions now on Zoom. We've got to update the slide. So if you need captions, you can use those. And then during any of our discussions, if you'd like to come off mute, feel free to raise your hand by using the raise hand function in the reactions. And I'll go ahead and pass it to Katie. Oh, who just got a bite to eat. I can go.
Sorry about that.
No, I'm sorry. I didn't see your chat till now.
It's okay, Laura. So as a reminder, this is the Comagine Health mission. Together with our partners, we work to improve health and create a better healthcare system so that people and communities will flourish.
Thank you, Katie. And I am Laura Jackson, the Director of Community at PFCC Partners. We are partnering with Comagine Health to facilitate this Patient Family Partnership Hub. Our mission at PFCC Partners is to reinvent the health system through radical collaboration by being a catalyst for system transformation and center the inclusive human experience of health. Our vision is a health system transformed, one that works with people and through communities as a partner in their well-being. You see our values here are equity, inclusion, diversity, collaboration, and solution focused. This is the Patient Family Partnership Hub, which encapsulates all of Comagine Health. And the Comagine Health states. We provide engagement opportunities, which we have a few we'll talk about towards the end of the meeting today. Some of you are joining us from existing PFACs. We do have a skills development opportunities. We have our online community and PFCC events. And our agreements we go through before each meeting, a couple include facilitator will provide context and discussion questions prior to the meeting. That is our invite you all get before the meeting. Parking lot is used to table agenda items. Meetings are recorded and the summaries are shared after the meeting. So if you have to miss a meeting, you can catch up by watching the recordings. Sorry, my cat wants to be a part of it too. And if you have any concern, you're more than welcome to DM myself, private chat myself, or any of the Comagine or other PFCC Partners team members. This is our agenda for today, and we've got lots going on. We're going to talk about the engagement opportunity process and how we can get involved a little bit earlier in the process. And then we do have some engagement opportunities that we will talk about towards the end. And we will do our check-in question. So let us know your name, where you're calling in from, and what is your favorite dessert. So like I said, I'm Laura Jackson. I'm the Director of Community at PFCC Partners. I currently live in Eugene, Oregon. Our offices are down in Long Beach. And my favorite dessert is anything that involves ice cream. I think any kind of ice cream. So we'll go ahead and get started. The first on my list, I have Linda.
I'm Linda Dreyer. I'm in Portland, Oregon, and my favorite dessert is pumpkin pie with a lot of whipped cream.
Ooh, nice. I like a lot of whipped cream. It's very important. Thank you. Anthony.
Hi, Anthony Sanchez from Albuquerque, New Mexico. Originally from Southern California. My favorite dessert is those peppermint and chocolate cookies at Christmas time. I wish they had them year round, but they don't.
Nice.
But I think I ate enough for a year, so I'm good.
You just gotta stock up during Christmas time. Thank you, Anthony. Donald?
I am Donald Morgan from Hayden, Idaho, and I believe my favorite dessert would have to be blueberry pie. Thank you.
Yum, that sounds good. Thank you, Donald. Let's see here. Bob.
Hi, I'm Bob Gretry, and I'm from Linwood, Washington, and I haven't yet met a dessert that I didn't like.
Love that. Sweet tooth. Thank you. Jan?
Can you hear me?
Yes.
Okay, I'm on my phone. I'm trying to get on my iPad so I can navigate a little better, but there's a kind of ice cream I really love here. It's called Extreme Fudge Denali Moose Tracks.
Ooh.
Ice cream with fudge and chocolate pieces in it. It's real good. I'm kind of a chocoholic, so.
Nice.
And I'm from Salt Lake City.
Thank you, Jan. Lindsay.
Hey everybody, I'm Lindsay Galley. I'm located in Sacramento, California. My favorite dessert, I was gonna go with just your simple chocolate chip cookie, but everybody brought up so many good desserts, so I don't think I can choose just one.
I know, kind of
here.
Thank you, Lindsay. Who do we have on the phone?
That was me. That's Jane. But I
Savannah's
am
on the phone too.
Recording in progress.
Ah, okay. We've got Savannah. Yeah, we can hear you.
Me okay?
Yeah.
Okay. Hey, I'm Savannah. Sorry, I'm doing school pickup, so
no problem.
a good time on the phone. I live in Smithfield, Utah. I am favorite dessert, anything involving cookie dough. I am a cookie dough fiend, so I'll eat it in any kind of dessert.
I love that. Yeah, sometimes I'll make it just to eat the cookie dough.
Yeah.
Thank you, Savannah. Katie.
Hi everyone, I'm Katie Frazier. I'm located in Portland, Oregon. And this is a hard one for me because I have all my teeth are sweet tooth. So I would have to say banana cake is my favorite.
Ooh, that sounds good too. Man, I always make myself hungry with these questions. And Alberta.
Hi everyone, I'm Alberta Davis. I'm in New Mexico and I like anything cake, anything with cake.
Nice. Yeah. Nice. Well, thank you. Thank you for joining us today. Check my list twice. I think we've got everybody. Did I miss anybody? All right. We will go ahead and get started. So today we are talking about patient-family engagement in Comagine Health and how we can be involved in the process of engagement. And one of our objectives and the key results that we shared in our last meeting, this is just one of them, is promoting and establishing meaningful engagement of the Patient-Family Partnership Hub, you all, and QIO program. A lot of acronyms there. So we wanted just to share this to level set a little bit of the discussion today. Did I miss anything? Lindsay or Katie?
I might just add just a little bit of context about objectives and key results. I know we talked a little bit about this on our last meeting, but it's really just a way for us as a team, so our organization PFCC Partners in partnership with Comagine Health, to develop some measurable goals around patient-family engagement. So, as we move through the year, we have something to measure to understand if, we are making a difference and change when it comes to patient-family engagement at Comagine Health. So of course we met recently, and a big part of that is communicating the partnership hub to Comagine Health staff and continuing to grow momentum of all of those engagement opportunities that have been coming in to continue to get all of you engaged really closely to the work that Comagine Health is doing. So yeah, just some additional context. And I don't know, Katie, if you wanted to add anything else, or Savannah.
No, I think that was great, Lindsay. I think what we're doing today will really kind of glean some more insight from the staff perspective and how the advisors can get engaged earlier. So I'm excited for the activity we have planned today.
Thank you, Katie and Lindsay. And I did want to introduce Alberta. I know you did your introduction a little bit, but if you'd like to come on and do a little bit more of a formal introduction and tell us your role within Comagine Health.
Sure. Again, my name is Alberta. I go by Bert or Berta, and I've been with Comagine for 10 years. So I've worked in the realms of chronic disease, specifically diabetes and hypertension, with self-measured blood pressure as a focus. Is that helpful? Also, I have been in the patient world, so yeah.
Yeah, thank you.
Nice to meet all of you.
Nice to meet you as well. All right, so what we're going to be doing today is what we call journey mapping, and Alberta will help us kind of go through her process of engaging patient-family partners in those engagement opportunities. So I'm going to, there we go. I have this Jamboard here. Can everybody see the Jamboard? Yeah, okay, cool. Oops. No. There we go. Okay. So what we're going to do is, Alberta, if you could walk us through a little bit of your process of engaging patient-family partners. And then we can capture that here on, this is like a timeline here.
Yeah. And
go ahead, Lindsay.
Sorry, Laura and Katie. I think where we really wanted to start, Alberta, was where, like, when you receive, or, when Comagine Health receives a task from CMS, because we know that, all of those new projects come in through Center for Medicare and Medicaid Services. So all of the steps that lead up to, when you would then come to the partnership hub, or when you would then start to engage patients and families in that work. So we want to learn about all of the steps that you need to take, the things that you would need to do when you receive some technical direction from CMS. Katie, were you going to add anything else?
Yeah, no, that was helpful. I was just going to say I'll play the staff role alongside Alberta, so we'll kind of tag team this. And to give everyone a picture, an example is CMS sends us a technical direction letter to our organization of where we need to focus. And so, like, I apologize, Bert, if I didn't give you a bunch of context in advance of this meeting, but I think what will be helpful for the advisors to see is kind of what we do on our end when we get new work. Like, how do we, let's say at our level, we're informed that we're on this new team. And then where do we start from there as we start to think about what the task at hand is?
Okay. So I'm assigned to the chronic disease portion, and specifically in the diabetes arena. So we're looking at like specific measures to identify folks with A1Cs greater than 9, and also to be able to find the patients that have not been in the clinic for a year who are missing an A1C test. And so this one of the first steps is who would like to work with us, who can we help to identify patients, to look at what is their workflow, how do they capture this information, how do you have a conversation with someone to not discourage them to continue their care, to not make them feel judged. So just some interviewing skills, and then some resources to be able to provide folks so that when there are questions coming at the providers, how do they answer them? What can they give the patients in hand, so that they can help to educate and learn about their conditions, and so that they can take more of an active role in their own care, so that it becomes a partnership within the provider and the patients. And so as a result, there's more engagement. And so you'll come every 3 months because you like the provider, you feel cared about, you feel cared for, you feel like you're getting everything that you need. And so and then as a result, we're also encouraging them to run reports to see, does that matter? Where are the gaps in care? How do we identify what else is keeping folks from being able to come to their appointments? Is it transportation? Is it, if it's a telehealth appointment, is it lack of understanding the technology, so intimidation to make the appointments? Is there food insecurities that keep you from eating as well as the providers are directing you to, but you live in a food desert and so you don't have that option afforded to you? It's kind of a taken for granted perspective. So there's lots of things that we do once we get in the mix of getting folks, providers, clinics to work with us to be able to focus on those measures. Is that helpful? Is that what you mean?
Yeah, that is awesome. So to think about it in kind of steps, like as we look at what Lindsay's populating, so Comagine Health receives this kind of direction that we have to go, and then a team is formed and they review the expectations. And then from those expectations, the teams start formulating interventions, or do they work to identify partners first?
We identify partners to then identify gaps of where interventions will be most useful.
Okay. Let me know if you need to slow down, Lindsay. Or Laura, whoever's, I don't know who's conducting.
I'm trying to keep up. So you review the expectations and then you identify those providers, and then providers, clinics, whomever, and then you create those interventions.
Yes. So it's twofold. It's how to help the provider and their team, and then how to help ultimately patients in the realm of patients, so that there's more of a partnership to be able to move the measures. So we don't want to lose sight of the folks that these measures are affecting in our own process, right?
I'm curious, when you get a technical direction and, you're reviewing those expectations and identifying the providers and clinics to partner with, how long does that typically take? And, how lengthy are the directions that you're getting from CMS, and the expectations that come along with it? I'm curious about the timing of it all.
sometimes it can be quite lengthy. Oftentimes CMS changes their mind. There are modifications, and now we're looking at this, and actually this has also been added, and now the measurement has become this instead of this, and in addition to that there is this, and so there's a high degree of flexibility that needs to come with this ever-changing need to be flexible and yet still be able to move the needles in what CMS is looking for. Mm-hmm. So I think that's kind of a complicated question to answer.
Totally, yeah.
Yeah, and so, and we're given a little bit of direction, but not a ton in the sense of, here's what we need from you and go. And so we, like right now we've come up with a chronic disease learning network series that we're looking at. There's this pandemic, right? And lots of folks got lost in the mix. They don't want to come in. They don't, there's fear and anxiety. There's literal barriers. Like you don't, if you're older and you have a chronic disease, how safe do you feel coming into a clinic where everyone's sick? How do you manage that? So we're looking at how do we get folks back into our clinics so that we can continue the care. And we're also addressing things like 2023 updates to the measures. Do the providers know how to bill for this? Are they capturing and billing the right codes? And then we, as part of the series, we also have how do you market and encourage and engage our patient population to come back into the clinics? And then the effective strategies that will work with that. We're also looking at what resources exist in your state. How do we set up referrals to evidence-based, what is the word? Evidence-based, like classes and such that support the community in their efforts to manage chronic disease. Things like diabetes self-management education, diabetes self-management programs, chronic disease self-management in your state. Who are the people that you can go to as a patient that will help you learn how to self-manage your chronic condition? And then we're also looking at helping the providers with identifying like codes and helping to screen for social determinants of health and how to bill for that as well. So how do you incorporate these? How do you incorporate this as a focus into your clinic so that you can identify what may be missing to be able to better support your patients?
Bert, I have a quick question. So when teams are working on these interventions and they're kind of, full speed ahead, and then CMS throws something in, do teams get shuffled up? Is their priorities refocused? And how do you keep your engagement going with your providers and your community?
Yes, we get shuffled about. People leave. We also have staff turnover. Sometimes they don't fill in the gaps with the person that left. And that affords us more opportunities to learn and expand our our scope. Sorry, what was the last part of your question?
And how do you keep that engagement going with these community partners? Like, how do you maintain that with all the kind of shuffle?
I think it's making effort to stay engaged, to update with webinars, to say we're going on pause, but we are still here. So if we were meeting with you once a month, maybe we say we have to pause and regroup on this, but our focus is not changing to address your patients. So I think it's just really important to be able to be honest about modifications, not necessarily like, oops, we're actually not working on that at all, but finding ways to integrate what we were working with that person, that location, to also switch and maybe integrate that additional ask, or to modify the additional ask to shift so that it doesn't even though it looks like, whoops, we're reversing and we're going in this direction now, it doesn't have to look like that to the folks, because it's our job to find a way to keep our mission in our minds, right? That it's not just about checking these boxes, it's about checking these boxes and serving our client. And so I think it's up to us to be able to work as a team to find a way to make that work for the folks that we're already engaged in, so that they don't feel like they're just in it for themselves. So you don't want to ever get that impression.
Mm-hmm. It sounds like a complicated process, to say the least. And I had another question, just going back to the timeline. So when you get a new task or a new modification, is there a timeline that goes with it when, you should report improvements back to CMS by a certain time?
Yeah, we keep tracking. We keep track for our director. So there's bullets monthly that we have to update: progress, successes, barriers. And then we also, for ourselves within our teams, create 30, 60, and 90-day plans that we can assign roles, so that we know what. I think it's really important as a team, as we're working together, to understand what our roles are and what the expectation is. I want to know the expectations of me and what value I bring to the team, so that I can elevate that and stay on task for myself. And I think if there are major hiccups within the team, then we can't stay as engaged with folks if we're not holding up our own and being accountable to our own selves as a team. Who's doing what is really important. Planning out and then modifying. The 30, 60, 90 is not, I mean, if CMS is changing the task that we're addressing, then the 30, 60, 90-day plan has to shift a little as well. So just being mindful and keeping track of all the moving parts as a team.
You have to be really flexible to do that.
I think CMS has a requirement in our contract: flexibility, like bold, underlined.
Yeah.
I'm pretty sure it's in our job descriptions as well.
Yeah, all of ours. I think anyone in healthcare has that, as a bullet in their job description, is you got to be flexible, because as we've seen, especially over the last couple of years, the healthcare environment, our own environments, are ever changing. Always. Are there any questions for Bert, just based on this process that you've heard today?
So at what point generally would you look for input from patients?
I think it depends on the realm that we're working in. And like one of the other contracts that I work in is around self-measured blood pressure, which is patient-centered. But we're not in the clinics asking patients. We're asking providers to give us patient input. What did your patient say when you suggested this? How does an action plan work when you provide it to a patient? What kind of feedback are you getting so that we can take it? We've also been afforded through Katie saying, hey, if there are any resources that you have that you want input from patients, send it on over. And so we know that we have that afforded to us as well. So I think that in that regard, it's kind of on the back end, but can be brought forward through this medium. And so it's, it's an advantage to have you all here for us to have that access to be able to say, we need feedback about this. And it may be coming soon, because we're in the process of developing some resources for this diabetes task. And so we're finally at that point now where it's like, okay, we may actually need to get feedback from folks, because we've been working hard to recruit folks to work with us and to get to know different areas of the state and what the state needs based on, a lot of times it's based on the area that they're located. So we haven't been able to, at this point, utilize that option too much, but I think knowing that that's afforded to us is really important to integrate into the workflow as we proceed forward.
I'm curious, Jan and everyone else, because that's a good question, where in this process you see maybe more opportunities to partner with Comagine Health in support of this, as you can see, really flexible, flowy process that staff goes through.
I was just going to ask the same question, Lindsay, like, to be meaningful for you, knowing that the project you're on might end suddenly because we have to shift priorities where engagement would be.
Is that a question to me or to the group? Wasn't clear.
Go ahead, Jan.
Well, I'm wondering, so if you go through these steps, when you're creating the interventions, I'm wondering even if at that point it would be valuable to have patient input, since they're the ones that benefit by these interventions and the help, then maybe even that early in the process. And I don't know if that makes your job more difficult, but I think that at that point, if you have patient input, then maybe those interventions will be more meaningful down the line, more on point. I don't know. What do you think about that?
I think that'd be a question for Alberta too. You know, we have this amazing group of patient family partners that are eager to partner with you. Is there opportunity to, you know, be a part of those conversations about the interventions that you're thinking to develop based on, you know, whatever the task is?
Yeah, definitely. We're working on a pilot program with those of you who live in New Mexico with Durans. And they're working with the Department of Health on a grant for self-measured blood pressure and also diabetes education. And so we're in the process of, hey, what do you all have as far as tools and resources that you give to your patients? So as we collect those, then we can definitely integrate that. And I think that would be a good point when they have given us what they're using currently to be able to pass that along to, you know, the patient and family group to be able to evaluate. Yeah, we love that. We hate that. And this is why. And that would allow us to be able to in turn develop or expand on the resources that they're already using or to modify them so that patients can, I mean, with direct patient input, then, I mean, if we're giving folks something that they understand, can relate to, and can take that and run with it, that would be the ideal, right? Because if we're just coming up with things on our own, I mean, I try to pull on my own personal experience because I've been through some stuff, through some medical stuff that, you know, I've not been treated fairly or well at times, or been heard, or felt like I was seen at times, you know, and it's quite frustrating. Or they'll hand me something that I'm like, this means nothing to me. I'm, you know, that's the truth. And so it allows me to be mindful of that when I'm working in the teams because I have my own personal experience.
Thank you, Alberta. Any other questions or comments?
This is Janice. I put one in the chat. So I'm really involved with measures and standards, also some standards development, and, you know, work. The level I work at measures, they go up to Health and Human Services and are adopted by CMS or not, right? So I understand how fast some of this can happen. And it is like you need to have like a rapid team, right? You need to develop a team that can implement this. And you do have a team mentioned, and on that team of, you know, stakeholders or whatever, I would recommend your communications and possibly your informatics, as well as I would add the patient and caregiver partners could provide input there too, which is actually, you know, a little bit before the creating the interventions. But it's possible to have somebody that understands some of the technical aspects to ensure that, say like there's the social determinants health HEDIS measures that have just come out, and they're on equity. And this year they're not mandatory, but they might be next year, right? So it's worth it to pick it up this year. But how do you do that social determinants health screening by having the individuals involved at different levels across is could be very beneficial.
Yeah, that's a great point, Janice. That team, we got a lot of great team members here.
Any others?
I think that if that is the topic, then, you know, I think everybody should start talking about it and start engaging on ideas or whatever. So I don't know what other people think, but, you know, there's things that can be started here, I think, you know, whether it's talking about telehealth or just asking the general public if they even know what their A1C is, you know? So, you know, that's my point.
No, that's a great point. And I think having that opportunity to be a part of a team like that, you know, and being able to brainstorm so what some of those interventions would be, those are really good examples. And, you know, we've done some brainstorming here in the past for some of the teams at Comagine Health that are working on those specific topics, and pulled all of your ideas together and reported them back out to the teams. And they have all of them and they're starting to go through them. So I think over, you know, the next month or two, we'll be back with some more discussions on, we actually got a bunch of questions on one of the documents that we shared with all of the ideas that we brainstormed together. So we'll probably bring some of those questions back to our next meeting to talk about more of those more specific concepts, like you were saying, Donald, you know, can we look at telehealth? Can we ask patients if they know their A1C? Like, what are other ways that we can do some of that, like teach back? Yeah, I think there's a lot more to it.
I was going to ask a question of the advisors. When we talk about engaging at this creating interventions level, I think PFCC partners and our Comagine Health team have really honed in on having like a clear ask of the advisors. So if there was an ask that came through just to like a higher level that a team is forming and these are what we're focusing on, is that kind of ambiguous information something you'd be able to work with and willing to join a team with, or do you need more specific information about specific interventions?
I personally think that's enough information.
Okay.
But you know, we got to kind of learn what the limits are too before you start a new project, instead of talking about things that are never going to get done. If we knew what your limits were, we could start from there and be more productive in a shorter amount of time.
Yeah, it's hard for us too as we get rolling, and then we have to switch get off the highway and get on a different one to just leave a project hanging. So I understand how that could be frustrating for you all to dedicate time to a project that just gets left hanging for a little bit.
But also, just so you know, it may look like that, but for me, I try to stay mindful of what I've heard and how can I use that going forward, so that even if we had to switch, from Highway 20 to Highway 90, then we are still carrying the feedback and the information that came to us. And I think it's really important to understand how powerful your voice is, as far as and then us being somewhat of a conduit to be able to elevate that, right? And so that we give voice to your voice, just like we try to give voice to providers and their struggle and their obstacles and their barriers. I mean, we're just kind of in the middle to be able to gather all kinds of feedback. And it's up to us to use it in a responsible way that helps to make the world a better place.
Yeah.
But that's what came into my head, so I went with it. But I just, I'm seeing things on the TV now, on the television, that say, have you been screened for CKD? Here are the signs and symptoms. Did you know this is silent? And I think that came from little groups somewhere going, I didn't know this was an issue. Why isn't anyone telling us this? Where are the providers? Why aren't they doing this early enough? Because now here I am with stage 3 and I had no idea. And where are we going to get that input in a focused way that we can go, this is a problem. We need to elevate this information to providers, and we need to get the message out. And this was something that was happening like a year or two ago, and I'm sure it's been going on a lot longer, but it came to my consciousness in that time frame. And so to be able to see actual, actual commercials that are encouraging folks. And I think a while back it was know your numbers. What is your A1C? Do you know your number? What is your cholesterol? Do you know your number? Now that it's February and it's focused on heart disease and stroke prevention, you're going to start seeing a lot more commercials elevated to messages to the public about screening for, heart disease and staying active and things like that, and I would hope that a lot of that information comes from the public outcry, like, this is ridiculous. Why did we not know about that? So even if it looks like a project is being dropped and the information may have gone nowhere, I would like to encourage folks to still always give that feedback, because it's important and it's up to us to keep it elevated and push it through.
Mm-hmm. And Britt, I think something that you said, and Jan, I see your hand up. I just want to touch on something really quick, because one of the things that we struggle with as patient family advisors, and I'm sure, you all have been there too, is just being able to see the impact that we're having by, sharing our experiences, giving insight onto, patient facing resources. And so I think just hearing your perspective and, you're the go-between and going to the providers and, gathering all the data to meet the measures, that it can be hard for you to then report that, like, how have you really made a difference? So I just appreciate you sharing, you are making a difference, even if you don't see it right in front of your face. I just think that's really important, because it's something that we definitely struggle with too, because an improvement in healthcare, it takes a really, really long time. So we may not see it tomorrow, but we may see it in a year and a half, just like you were saying. So yeah, that the whole timeline and the journey that we're on in improving healthcare, it's definitely a long one. And sorry, Jan.
No, that's okay. So I have a question for the staff. It would seem to me, in the example that you're giving of diabetes, that it would be really important for the patients who are giving input to have similar problems or similar conditions as to what you are trying to create the interventions for. In other words, you want to find people who are dealing with diabetes. Is that right? To input to a program that's creating interventions for diabetics. Is that true? Or
I would say it depends on the intervention. So if it's just patient-facing material, I think any patient can provide language and insight on how we would, grab the attention of the patient. If it's condition specific about what you might have experienced in regards to like signs and symptoms or something like that, then yeah, it might be more beneficial. But yeah, I think there's opportunity across the board.
Okay, I was just going to say, I think when you want, you need to make that information known when you ask for patient input, what kind of patient you're looking for, something general or something more specific, disease specific.
That's really helpful, Jan. Thank you.
Bob, go ahead.
All right. Yeah. I want to say you've laid out the problem really well. And I am learning on the fly. But I think what comes to my mind most is what do you want from us patients? What can we do for you guys? What is the, exactly that? What is it that we can do for you guys?
I can start. Anything. I think there's so many different things the patient can do. I think one, you bring your perspective. You're the customer that we're focusing on. So you bring your perspective, and we don't have that internally. And then two, also use your community. So if we have an intervention and it might relate to your community, reaching out to your community and inviting them on for their input and bringing that back.
Okay.
Yeah, I mean, I can't think of them all right now, but I think multiple ways. I think the thing that I struggle with is making sure it's meaningful for both sides.
Okay. Yeah, one of the things that I was kind of picking out of the conversation was about the blood draws and diabetes things was, I asked the question about what group of patients are we talking about? Because my world is transplant, kidney failure, dialysis and whatnot. And in my world, blood tests are done on a regular basis, right? So I'm assuming that when we're talking about this intervention, it's the community at large. So you're trying to figure a way to get people in to do blood tests for their diabetes on a regular schedule, right?
Yeah, this contract is focused on Medicare.
Right, exactly. All right, good. I needed, I'm a concrete kind of guy, and I like to have things kind of laid out so I can get my mind wrapped around it and learn faster. But thank you for that update. And like I said, I'm willing to help in any way possible. I will share my community with you as much as I can. I do run a nonprofit working with support for dialysis and kidney patients. And we would love to help you, but I just need direction.
Mm-hmm.
All right. Thank you, guys.
Thank you, Bob, and welcome to your first patient-family partnership meeting. Bob is joining us from the ESRD Network Advisory Council, so we appreciate you joining and being that connector as well, and opening this up to your community also. So thank you.
I would add to that to bring your authentic selves. Like we want to hear it, all of it. Hate it, love it, this would make it better. What is it like? What do you feel when you read this or when you see this? Does this make sense? It may make perfect sense to us I work, like I said, I'm also I've based on the medical issues that I've had, I've been through the ringer with that. And so I can bring my own experience, but my own experience is just one experience. And so I think as a collective mind, hearing, is there consensus about what we're bringing, or do the majority of folks just really hate it, and why, and how can we make this better? And so I think there's not really, there's nothing you can, all you can do is help to make what we're doing better. was really the bottom line for that, I think. And it's up to us to remember and put that in our own focus to bring it to you all for that input, like Jan was saying. So I appreciated that.
All right, I'd love to help.
Yeah, Bob and I are kind of from the same department. So, you know, diabetes, you don't want to see us later. So, you know, kind of goes hand in hand. So we'd love to help you guys out for sure in this thing going.
Thank you, Donald. And thank you, Bob. Any other comments or questions before we move on? All right, well, thank you so much, Alberta, for joining us and providing all this great info. And yeah, thank you.
You're welcome. Thank you.
Thank you, Bert. You can hang out too if you want. You don't have to leave.
Yeah. I'm going to go ahead and get the slide deck back up. Give me one moment. Okay, there we go. All right. Well, thank you everyone for that great discussion. We have just a few moments left. We did have this scenario here, but I think, Katie, do we want to save that for next time maybe?
Yeah, we can talk about this planning for next time.
Okay. All right. We actually would like to get to some engagement opportunities for you all. We have the primary care focus group for Medicare beneficiaries. We talked about in our last meeting. Lindsay has been helping, and Katie have been, and Linda, I believe as well, have been helping with the planning of this. Lindsay, do you want to talk real quick about it?
Yeah, we're still working with the team to develop, some of the criteria for this focus group so we can have a really focused discussion. And they're really looking, their goals are to decrease frequent hospital utilization, or people who go to the hospital, or the emergency department many times. So understanding what the barriers are between, access to primary care and things like that. They're also looking at reducing readmission, which is the same thing, coming back to the hospital within 30 days after someone has left the hospital. So the plan is to have the first focus group on February 28th. And again, this is open to Medicare beneficiaries who, have received healthcare. If you have emergency department experience, then that's great too. If you've been readmitted to the hospital, that would be helpful as well. But just anyone with experience in accessing healthcare from the Comagine states, which all of you are. We'll have some more specific information coming out soon, but if you are interested, and I believe, Anthony, you had expressed your interest in participating at our meeting last month. I kind of jumbled that up because we're still in the planning process, but Linda, anything else to add based on our last discussion with that team?
I think you covered it.
All right, thanks, Linda. Yeah, so more information to come.
Thank you. Thanks, Lindsay. All right. We'll move on to the next one. So this comes from us at PFCC Partners and PFA Network. The CMS, and we're partnering with Acumen, and they have a new field testing survey out, and it is currently open, and they're looking for patients and families on feedback on, can't say any words today, on feedback on draft measures specifications. So they're looking for people with the 5 conditions here. So kidney transplant management, prostate cancer, rheumatoid arthritis, chronic kidney disease, or end-stage renal disease, to fill out the survey. And I will put the link in the chat. Oh, that's not it. Now, there we go. And so they are the survey's open until February 14th. So if you have any lived experience with any of those conditions, feel free to fill out that survey there. And then lastly, we have our PFCC conference coming in May, and that is in LA at the California Endowment Center in LA. Information and registration is on our website, pfccpartners.com. And we will be on May 1st having a patient family community open house, and you're more than welcome to, if you're attending the conference, more than welcome to join us on May 1st as well. We are still in the planning of it, so more information to come with that one. And then there is an opportunity, Katie, if you want to talk a little bit about the opportunity for folks to come to the conference.
Sure. So Comagine Health will be paying full room and board for 2 advisors to join at the PFCC Partners Conference in May. So if you are interested, please let us know. That covers your flight and your board, and I'm sure some stipends for meals.
And I will say, in that patient community open house, the day before, we're going to have a table for each. So we facilitate a few other communities like this, hubs. So there will be a Comagine table. So if there's any other patients that happen to be there from the Comagine Health states, they can learn a little bit more. So would love to have, if you are there for the conference, for you to join us.
Mm-hmm. Thank you, Katie and Lindsay. All right, so that'll be it for today. Our next meeting is March 2nd, same time, 3 p.m. Pacific, 4 p.m. Mountain. And if you have any questions, feel free to let me know. My email is there on the slide, and we'll see you all next month. Thank you.
Thank you.
Thank you, guys.